am also the radiation safety officer. So here's going to be our annual fluoro training. So I just wanted to say, like, my goal in spending a lot more time in the cath lab is for us to optimize patient dose and to minimize occupational dose, so all of your doses. We don't want to minimize the patient dose, we want to optimize it. We want to make sure that the physicians are actually seeing what they need, because if we're delivering dose and we don't get the diagnostic information, then we just wasted dose and we overdosed the patient, which doesn't really make a lot of sense. So that's the goal there. And I know that adverse events are going to happen. You know, people are going to get, you know, skin burns. You guys do really complex cases. You're saving people's lives. But what we want to do is to minimize that and also minimize your risk by minimizing your dose. So what we're going to talk about today is a little bit of radiation biology. Hopefully this will be somewhat of a review for you guys, and if not, please ask questions. We're going to talk about new placement of your occupational dosimeters, your badges. We're going to talk about ALARA principles and different tenets for minimizing risk with the fluoro units. So I first wanted to say thank you for getting me all these measurements. You guys are taking the widths of the patient, and you're also writing down the air Kerma for me when it exceeds 3,000 milligray. And what that does is it helps me to calculate the peak skin dose for these patients with much greater accuracy. So I want you to know that by doing this, you're helping me, you're helping the patients, and so it's really important. I just wanted to thank you for doing that. So like I said in the beginning, I'm the new radiation safety officer for Mercy. Before me was Dr. Bischoff, and he came every couple of years to give you the safety talk. I'm going to be coming every year, and I now have a desk by Nancy, and so I'm going to be on site about like 2 to 3 days per week. So if you have any questions or concerns, like, come see me. They'll make my day. And if you want to know, you know, how are your badge readings, you have concern about your eyes, you know, someone's going to be pregnant soon, you want to talk about anything like that, I'm the person to see. And so I work for Mercy Des Moines, but I'm spending most of my time in the cath lab. We've had a couple of, you know, adverse events that were pretty significant, and so Mercy has decided to allot me some time to kind of, you know, update policies and procedures and, you know, make some changes. So here's the thing. We have radiation dose in our lives all the time. We go through those airport scanners. That doesn't really bother us. We live in Iowa. Most of us have radon in our basements, but we know that's pretty safe if it's under a certain level. But we also know that radiation can also do really bad things, like the Chernobyl meltdown. This is a picture of the liquidators who went and cleaned up that disaster. So the hard part is finding out how much is too much, because we have it and it does a lot of great things in our everyday life, but at what point is it too much and causing too much risk? And one of the reasons why this is so difficult is because, you know, we can't see radiation, you know, we can't smell it, you know, we can't touch it, and we have to measure it indirectly. So really, it's a balancing act. You know, without, you know, radiation, we couldn't do pretty much any of these cath lab procedures. So we have to have a very healthy respect for it. So in the scheme of the hospital, you know, how much radiation does the, you know, cath lab department have compared to other departments? And so it's actually pretty high, you know, compared to just people taking x-rays or compared to CT. You guys are dealing with more radiation. So that means you guys should have more training, right? Or at least more than you do at this moment. So that's why I'm here. So we know radiation can cause negative effects, so let's kind of just break that down a little bit. So there's two different type of main effects that can happen to the body. There's the stochastic effects, and these are, most likely you think of as like cancer. And these are an all or nothing type of thing. And you don't see the effects from like a radiation dose for years to decades. Then there's deterministic effects, and these happen sooner. And here, the severity is dependent on how much dose that you get. So the more dose you get, the more severe your side effects. And examples of these are like skin burns or cataracts. And you don't see these effects for hours to months to maybe a year. So to just talk about this a little bit more, I'm going to show you graphs because that's how I think. But for deterministic effects over here, you can see that there's a threshold. So up to a certain point, you're fine. Nothing's going to happen. And so this is like with radiation skin burns with a patient. So up until about 2 gray, there's no real risk of them having any type of skin burn or erythema, which is just kind of like a sunburn redness. Same thing with cataracts. Up to a point, you're not going to get radiation-induced cataracts. So our goal is for us to stay below that threshold. Obviously, that's not always possible, but that's our goal. And the reason why these effects occur is due to cell killing. Like radiation will come into the body, and it will kill a cell. And then because that cell is, killed, then you see these negative effects. Now on the other side, this stochastic effects, this is caused by damage to the DNA. And so remember I said that this is like cancer, and you don't see those effects for years to decades. And it's because there's a mutation in the cell, and there has to be a lot of other things, like 5 or 6 other things that have to go with the mutation. 5 or 6 other things need to happen, and then eventually down the road, 20 years from now, you might end up with cancer. So for our purposes, we really kind of more care about, the skin, erythema, and breakdown, and cataracts. And right here, this is, if you ever want to rile up some physicists, talk about this right here. This is the linear no threshold model. So according to a lot of scientists, there's always a small amount of risk that you would develop stochastic effects, even just like everyday radiation. But there's some physicists who completely disagree with that, and it's people fight a lot about that. So skin reactions. This is kind of the most important stuff for you guys. So one of the really hard things to understand is that somebody might come in with for a CAT procedure. It might run long, it might be really difficult, and a week later, 2 weeks later, everything looks fine. But 3 weeks later, a month later, a year later, they can have really terrible effects, but they're not going to show up right away. So that's one of the reasons why a lot of injuries from places like the cath lab or IR, people don't associate them, and then they don't get treated appropriately. So this is kind of a really famous graph. And over here we have skin dose, which is not the same thing as air kerma, but they can be they're closely related. And so 2,000, 2,000 to 10,000, 10,000 to 15,000, and then you look across over here, and then you can see, is there going to be a prompt reaction within 2 weeks, an early reaction between 2 and 8 weeks, midterm 6 weeks to a year, and then this is actually supposed to go the other way, greater than 40 weeks. And so you can see that as the dose to the skin increases, so does the severity. So at the low end, you can get some, it's going to look like you're out in the sun, you got a little bit of a burn, and that can go all the way up to them needing a surgical intervention because the wound won't heal. So I'm going to show you some pictures of that. So this is like worst case scenario, guys. So I'm just going to show you guys worst case scenario. So here's a really mild these are the ones that we think are, just fine. We let the state know, but it's not that big of a deal. So this is faint erythema, and this is transient, meaning that they're going to have this basically like sunburn, but it's going to go away. So that's fine, not a big deal. And this is between 2,000 and 5,000 milligray. Now, if we go between 5,000 and 10,000, there's like moderate risk. It's going to be more than just a sunburn. There can be some permanent hair loss. It'd probably be on somebody's back, so I'm not saying that's like a really terrible thing, but it can be painful at this point. So this is the part that we never want to get to, is this between 10,000 and 15,000 milligray, because there's severe breakdown of the skin, and it weeps, it's really painful, and this isn't going to go away for over a year. And it's going to take, up to a year to get to its worst. So, yeah. Now, if you get over 15,000, this is what happens. You get these wounds like this that can't heal on their own. And so this wound right here used to look like this. And it didn't occur until, like a month afterwards. No one gave him a heads up that, if you have this cath procedure and you have a high dose, you can have a skin reaction. So he went to several different doctors to find out, why does his back hurt, what's going on. They did a punch biopsy, and then that wound didn't heal, and it progressed to this, and it kept getting worse. So this is why we're following up with patients, so that doesn't happen. This wouldn't have been as severe if he didn't get that punch biopsy by a dermatologist. Okay, now the worst one, and then we'll be done with gross pictures. So this is why follow-up is important. So this is the worst one. On the right, that's somebody's like bone exposed. And you guys have probably seen this picture, it's pretty famous. And so this patient had an EP procedure, and their elbow was really close to the port. It was under a drape, and nobody noticed. And so this patient, they didn't even get any redness for 3 weeks. So again, this is why the follow-up is super important. And so at about 5 months, the wound started getting really bad. At about 6.5 months is when you started being able to see the bone. Eventually they had a surgical intervention, and they put a flap of skin over it, and it was a lifetime injury. Eventually it was covered, but so here in this cath lab, we have had 2 episodes where the peak skin dose was at this level, where they're going to have surgical interventions. So our goal now is to take this a little bit more seriously and to figure out ways that we can, do the procedures, have the patients, remain alive with the great work everyone does, but maybe just pay a little bit more attention on a lot of small tweaks that we can do to lower the patient's skin dose. So what's our game plan now that I just showed you all these terrible things? So our game plan is to use the ALARA principle, which is to keep things as low as reasonably achievable, and to follow the cardinal rules of radiation safety, time, distance, and shielding. I'll get into that more. And then we're going to talk about the major, well, I spelled tenets wrong, but fluoro safety. So, these first ones are just going to be super obvious, and you already know them by heart. So one of the things is that, we want to reduce the amount of beam on time. And I realize that nobody in here is the one pressing the pedal, but the more the beam is on, the more dose you're getting. So, if you're comfortable, and hopefully everyone is, to say, if you see the physician stepping on the pedal but doing something else and not looking at the image, nudging them, saying something, so that we don't have that wasted radiation. Because we don't want anyone to be a lead foot. And Mercy, you know, the powers that be, we're trying to get all the physicians to go through extensive fluoro training. So we're working on that. So we're doing you guys first, and then we're going to try to get them all trained up. Distance, that's the next one. So where is the dose the highest? So you know where to stand, when to take a step back. So if the tube is AP, where here's the tube, you know, shooting out the radiation, here is where it's the highest. And so that's why we have those skirts on the table. So it's really important that we can keep those skirts in place, because look at all of that radiation that they're gonna block. Another thing that you can notice in this picture is that it's great when physicians are taller, because the taller they are, the lower amount of dose that they're going to get to their eyes. So that's a huge benefit for our tall physicians. And that would be terrible for me, but that's okay. So again, here's a look in the lateral view. This person is standing right by the tube. If you can avoid standing by the tube, do it. Because look at all of the dose they're getting. So the colors here, red equates to like 8 milligray per hour. If this person could just back up a foot, they're going to be in the 4 milligray per hour. So if you can just back up a foot, you're probably going to lower your dose by, you know, a factor of 2. So back up a foot, back up a meter whenever you can. And then distance again, but really I just kind of wanted to show you this picture of how dose increases so much with patient size. So here is the same patient setup. The only difference is that the patient is a lot bigger. So the bigger the patient, more of the scattered radiation. So those big patients where it's really hard to get good image quality, you're using a lot of dose. So their cardinal role is shielding. So I don't know if you guys have heard about this, but they're called these like zero gravity suits, and it's like a suit that you stepped into, and then it's attached to the ceiling. So when we think about ALARA, it's like, what is reasonably achievable? It's probably not reasonably achievable to put everyone in these full body suits, you know, with shields, but what is reasonable is for all of us to wear lead, right, wrap around aprons, and then to wear our 2 dosimeters. And so what we're going to do moving forward is that we're all going to have one at our neck on the outside of our lead. And the reason why we're going to wear it up here is because I want to see how everyone's eye doses are. I want to see, does anyone need lead-lined glasses other than the physicians? So very important, wear it up here. I'm going to be checking everyone's battery genes and seeing if anybody else needs lead-lined goggles. And then the second badge, wear at your waist, or between your chest and your waist, under your lead. So that's why it's a lighter color pink. That's what I was trying to show anyway. And then again, lead-lined goggles, and then we want to use all the shielding that we can in the room. So I don't know if you guys know this, but one of the reasons why it's so important to wear your lead apron is because it blocks 95% of the radiation. That's pretty great. So definitely wear that apron. What's wrong with this picture? This guy isn't wearing his thyroid collar, so we always want to get those on too, okay? That's the main thing there. Okay, now we are up to shielding in the actual room. So I'm just going to kind of point out the good things that they're doing here. One, the eye is almost touching the patient. So this is something that is huge. The further the eye is away from the tube, the harder the tube has to work. The harder the tube has to work, the more dose. So you pull that eye down, you lower your dose, the patient dose, and everyone in the room. So if you're also having trouble with image quality, you got a big patient and you're not getting the images you want, lowering the eye is going to help with that. The movable skirt is there. They're using it. They didn't kick it away, so that's great. And here's the movable shield. One thing I wanted to point out by this is that often people use that movable shield wrong. You want that pushed up as close to the patient as you can, and obviously there's going to be some procedures where you can't put it in, and I get that, everyone gets that. But if you can, put it in there. And you want it to be as close to the patient as possible. Some people think, oh, I just want to shield myself, so I'm going to put it close to me as possible. But think of it like this. If you're a little kid and you're playing with a flashlight, and you wanted to block some of the light, what are you going to do? You're going to smack your hand all the way on the top of that flashlight. Pretty much no light is going to get out. So that's how we're going to use that movable shield. Yeah, and then this physician is wearing lead-lined glasses, and we're saying that he's wearing his lead apron underneath. And then this nurse is behind a movable shield. So that's good. If you have them in the room, use them. So like in a situation like this, she's probably blocking, 95% of the dose here. Now she's blocking another 95% of the 5% that came off of that. Her dose is like negligible at that point. So our checklist for setting up shielding in the room, sorry I'm like really redundant, but hopefully it'll get in there, is the curtain on the table? Are the shields in place? Is everyone wearing lead? Is everyone wearing badges? I know that in the past that has been a problem, but I think you guys are doing better. Is that right? Yeah? Okay. And then my big push coming up is for the physicians to wear the lead-lined glasses. And I've gotten some pushback on that, and I talked to Dr. Ghali, and I found out he actually has radiation-induced cataracts. So, it's important, and that's something that I will be talking more about with them. Well, that's okay. You have anything?
No, she said did not Dr. Ainami, and I don't know how long ago he had his. I would expect his were probably the same.
Oh, okay. That's good to know. Okay, so your badges. Sometimes they can get confusing on where to wear which one at which position. So here's a little key. So the ones that are in red, they should go up here, and the yellow ones should go at your waist. If that gets mixed up, your badge readings are going to be, and they might not be on this badge yet. The colors, are they black still?
Yeah.
Black and yellow.
Black and yellow.
Okay, so I recently changed the way that the badges are being read because the black one is assuming you're not wearing lead. And everyone is wearing lead, right? So, and also due to the placement of the black, I'm not getting an accurate value for your eyes. So I called them up and I said, please let's change this. They said no problem. So your next batch, they're going to be red and yellow. But go ahead and wear your black ones up here for this month. And then next month they should all be new. Okay. Alright, so next couple of pictures are not super high quality. Sorry about that. Okay, now we're going to talk about how patient thickness exponentially increases the absorbed dose. So I said that kind of backwards, but alright, let's look at this 15 cm patient. ESD, we're doing the entrance skin dose, okay, has a unit of about 1. Alright, if we double that thickness of that patient, now the entrance skin dose is about 8 to 12 units. So every single time you go up by 5 inches in the patient thickness, you are basically doubling or tripling the dose. So that's not something that is intuitive, but that is something that happens that everybody needs to remember, because this is going to help you, 1, with your image quality, and 2, it'll help keep the dose down. So let's kind of see this in action. Here's the same patient. If you're just doing a straight AP on a thin patient, your dose rate is going to be between, say, 20 and 40 milligray. Now, if you have to do like a very, like a real big oblique, the dose rate is going to shoot up, and your image quality might go down. So now the absorbed dose rate is around 250 milligray. So, I mean, that, really shot up. So if you're having a hard time with a big patient, with the image quality, do your best to stay as AP as you can. And obviously, you guys need very specific views. So, that's challenging, but just keep that in mind that that is what's going on. The next thing is to choose an appropriate dose rate. And what everyone should be thinking at that point in time is that you want to compromise between image quality and the dose rate. So, what can the physician tolerate, getting the amount of information they need, but nothing extra. So I wanted to compare acquisition and flow rates. So one of the adverse events that we had, somebody was stepping on the acquisition pedal for a long period of time, and it looked like they were basically using that as regular flow rate to just improve image quality. So that's bad. Why? Because that acquisition pedal, depending on the setup of the room, but it can be as much as, 60 times the dose to the patient. So, dose rate. And under federal law, Iowa state law, the acquisition modes don't have a tolerance on how high the dose can go. Regular fluoro does, and so we can kind of manage that. But if we have a physician or somebody who just loves just taking one shot after another of the acquisition mode, we are going to get just really high doses. So, if you have to go from, 7.5 frames all the way up to 30 frames, do it. Avoid the acquisition mode as much as you can.
So acquisition is cine?
Yes.
Oh, okay.
Mm-hmm.
Sorry.
Yeah. So it's stupid. It's definitely not stupid. There's lots of words to say these things in different ways. Oh, well, that didn't work out well. All right, how fast are your eyes?
Okay, do it again.
Got
it.
Okay, sorry
Orange and
about
green.
that. Okay, so what this is trying to say is that you move the table up, you increase the distance from the tube
Bless you.
to where the table is, and you're going to lower the dose. So as much as you possibly can, I know you guys set up your patients isocentrically, so this is asking you for like kind of a departure from that. But when you can, raise the table up as high as the physician is comfortable to work at. And that's going to lower the dose to the patient significantly. And the reason why that happens is because of the inverse square law. So anytime that you double the distance, you're going to reduce the dose by 4. And the reason why you're doing that is because the X-ray photons are spreading out over space. So that's the same reason why you want to take a step back from the radiation whenever you can. Okay. All right. So we're gonna see this again. So here's our just starting point. Now if we reduce the space, move the table up by half, we're going to reduce the dose rate by 4. And then if we move the table up another unit, then we're going to reduce the dose by 9. So, important. Next thing we want to do is collimate. So, if you can collimate to the area of interest, one, you're going to reduce the dose, which will be really helpful. So on the left-hand side, you can see the dose dropping. But the other reason why it's really important to collimate and to use your wedges is because it's really going to increase your image quality. So you can see on the left to the right, if you just collimate in, you're going to have brighter white and darker darks. And so you're going to have better contrast, so the physician, it'll be a lot easier for them to see. So as much as you can help your physicians pull in a wedge, collimate to the area of interest, one, that's going to help with the overlapping fields be a lot less. And two, it's going to increase the contrast, so they'll be able to see. And 3, by collimating, you're dropping your dose. So it's a win-win. Anti-scatter grids. So when you have the grids in, it increases the dose. But what you get out of it is far superior image quality. If you have a large patient and you don't have the grids in, there's going to be this haze over the image. And your image quality is going to be terrible. It's just going to all be gray and really flat. So you want to keep the grids in. I heard about a situation where there was like poor image quality in room 3. It was a big patient. They're having a really hard time. And they pulled the grids out. Well, that was backwards. So that's just going to make the image quality worse. So remember, big patient, always keep the grids in. Medium-sized patient, only time you want to pull those out is for peds. So this is kind of just a rundown of everything that we talked about. And I went really fast, I guess. So number 1, the thicker the patient, the dose rate is going to exponentially go up, and every 4 to 5 cm of tissue is going to double your dose. So, patient population is getting a lot bigger, so this really means you guys have to have a lot more skills. Number 2, set your dose rate and controls for the best compromise between image quality and radiation dose. So, if you can get away with a lower frame rate, if you can get away with fluoro negative versus like fluoro plus, go ahead and do that. But if you need fluoro plus, go ahead and do that before you step on the acquisition pedal for the regular part. If you need cine, that's fine, but just try to limit it. You want to keep your beam on time to a minimum. Make sure the physician is looking at the screen. We don't want to waste dose. We want to keep the patients the table as high as possible. Keep the II down as much as we can. This is something we didn't talk about, is don't overuse the mag modes. That will increase the dose. 7, keep the grids in for large patients. 8, collimate to the area of interest. If you have a really bright spot in the image, have a physician pull in a wedge. And then number 9, we're going to monitor radiation utilization, and that's something that I'm working with Nancy on, and something everyone's helping me with is by writing down those patient doses, so we can kind of track, okay, what type of procedures do we have the highest dose? What can we offer everyone in that room to lower it? And number 10 is make sure that everyone has radiation safety training. You're all here, so for 8. Okay, does anyone have any questions? No? Is this a review?
Yeah, it was easier to understand than I thought.
Do all of our cameras have those grids in them, like 3?
I only think that 3 has removable ones, but I could be wrong.
I don't know that we.
I don't think any of the others are removable.
Three's the only one.
Okay. So does everyone here work in all of the rooms, or are all of our room 3 people away right now?
Everybody works in.
Those guys work in
Oh,
yeah,
the
everybody
peds,
works in
yeah, they're in room 3 right now, is that what you're asking?
But you
Well,
do EP
everybody
in
else
3.
kind of
Everybody
all-
goes
I
into
do
room
all
3.
room
Everybody
three.
does.
Okay.
It's gonna sound like a dumb question, or are we not worried about, like, arm long bones being covered? Why I asked that is I had seen one physician that actually had a sleeve on it, I believe, on his left arm, went down to his elbow.
So for the physicians, are we
Yes.
worried about, okay, so the dose that you can get to your extremities is about like 100 times greater than to the core of your body. So as a rule of thumb, we're not as worried about that because it takes a lot more damage, or a lot more radiation to cause the damage to the arms. But
Because
if
when
they're-
when we do devices, we work cross table from the physician, so we're just as close to the tube as the physician is on that side, on the patient's right side most of the time. So that's why I was wondering.
Okay, well, let's pull up the picture so I make sure I understand.
If they aren't using it, you could also do the pull down shield on your side.
Yeah, the tissue there, never used
Because
it.
there's
Yeah.
really no reason for you to
there
not
is
have
one on that side.
protection, so
Yeah.
you could pull that
You guys
shield
never
down
use it
on
out.
that side. Cause they won't put
You
it in
guys don't
front of
use it.
them because they can't
Yeah.
do what they're doing then, so just use the pull down shield on your side.
Okay, so are you on this side? Is that
I'm
what you're
sorry?
saying? Are you on this side over here? Is that where you are?
But more like this, not in the
If the
ladder.
doctor's,
Incorrect.
if the doctor's doing a
AP.
pacemaker on this side, the staff is up
Or
on the
the
patient's
AP.
shoulder.
Like that picture on the left, it's just a
Yeah.
mirror image
So
where
then
the staff
doc-
is.
so
Oh,
then the
so
tech
then
is
they're
on the
right
other
here.
side.
And the
On
staff
the
is
on the
just
opposite
on the
side
left.
too.
The tech is that, where the doctor is.
Okay, gotcha.
The doctor's on theirs.
So the doctor and the scrubber are sandwiched to the.
Straight across from each other.
Yep.
With a tube in between it.
But it is fluoro, usually.
Okay, yeah.
So I said they could just, you could put the pull down shield on the right,
And
in
then,
between
yeah, I
him
forgot
and
about that one.
the tube, because the physician doesn't use it
Yeah, that would
in
be
that particular case.
a good plan.
Until you're trying to use fluoro and do something.
Till what?
Until you're trying to use fluoro and do
Well,
something. You have a
Then just
shield right-
move it,
right
I mean, I
there,
would
so you
still
just-
put it there, that's better than not being there.
Mhm.
Okay.
Or just buy some lead glasses, make sure you have your thyroid collar on, and that, what do you call it? Bengali wears with the lead in it on the little hat.
I think we have some of those hats too here that have the
Lead in them.
lead in them.
Yeah, the thing about those is that, couple things, they don't protect as well as you would think, one, and two, well, your skull actually protects your brain a lot. So by wearing that, you're welcome to, but you're only probably saving dose to your brain by like 3 or 4%. So if I had to pick what I was gonna do, I'd be annoyed with the shield a little bit, cause that's gonna save your eyes, which is a lot more sensitive, and your thyroid and the things here, these are what's a lot more sensitive.
What about using the rad pads? Does that work very much?
I'm not really familiar with the rad pads.
I know they're in the shelf, but I don't think hardly anybody uses them, do they?
Are you
Just
using-
dropped it. Who was using it? I can't remember who was using it.
Also the-
I use them for
I don't know,
peripherals.
Let me get back to you about the rad pads. Anything else you guys are wondering about?
Westlakes, any questions?
Are you there?
Do you have concerns in room 6 for the wall, internal wall in there with no lead in it?
I did make a recommendation that we should put, like a half window, a lead line half window. I think as far as the whole like reasonably achievable, you know, that would save a lot of dose to everyone sitting back there, you know, in the scheme of things, it's pretty cheap. So, yeah, I think that's a reasonable thing that we can do.
Could you put like, you know, our wall, free moving blockers, can you put those along the bottom? I guess I haven't been in there enough to see how much room is, but you know, the low wall, well, there's no lead in. Could you put like temporary barriers across there?
Should be lead in that.
There's not.
There's not.
There's not. In
There's-
room 6?
There should be.
I know there should be, but there's not.
Oh, wow.
You know, cause we have the tall clear one, could they make one that's horizontal
I
that you
didn't
could
either.
park right there?
You could, but thinking about what is the most sensitive on the body, I would feel safe with just the lead glass in there.
That's what I would say, I'm like, I don't know why they didn't just put a half window in that.
But the other thing is that everyone that should be in there should be wearing lead anyway. So the thing that we're really saving is eye dose by putting that lead window in. Cause the core of your body is gonna be protected by your apron. Are people sitting back there without any lead on?
No.
Because they know
But that's
that's
kinda
not-
that's misleading though.
Is your lead still protecting you?
That's way misleading.
My lead
room
doesn't.
3 is, I would assume so, correct?
As long as you're not sitting like this in front of that wall. Gotta sit like a lady.
I mean, by the time I sit, I'm not tall enough for my lead to, I just wanna go down over the chair.
Because of the way that your body is oriented, I would feel safe doing it.
Just curious.
But you're
Yeah.
far enough away too back there.
Yeah.
Your exposure at that distance is
Pretty
like,
minimal.
it's
Pretty
still.
minimal.
Correct.
I'll
Yeah.
agree.
Yeah.
Yeah.
Yeah, I did not design that room, so I.
Neither did.
Neither did any of that.
Yeah, so when I came in to accept it, I'm like, wait a minute, like how, you know, I had set up my report and I was very surprised, but, given your eyes are far more sensitive than, you know, your internal organs, you know, here, so I think it's very reasonable to put lead-lined, glass in there, and then I would feel like we have done our absolute due diligence, and I would feel safe, you know, sleeping, eating back there, so. Yeah, I mean, 24 hours a day, it'd be
That
fine.
helps. That happens
Yeah.
all the time.
Yeah.
Well, that's gonna go well.
You got that recorded, right?
She had one. Scan her room.
One thing about the slide that you have up there, what might be useful is to put distance from the tube out this way, you know, from, to behind the position, you know what I'm saying, on the left image?
Like here,
No, on the left image.
yeah,
So say from the tube to where he's standing and then
Yeah.
out to each one of those gradients.
How
Oh.
far away that is.
okay, so I guess you need to like think like this.
Yeah.
So, yeah, it would be easier if it was,
Okay.
yeah, like, here's your key.
30.
Yeah, so not a, you know, you can think like that. Okay, well,
Thank you.
Thank you very much.
thank you.
Appreciate it.
That's very